भगवती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Pleasant evening to everyone. I welcome you all for the IACA Physics webinar series, and this is the fifth session in the series. So we've been covering a lot of basics in MR physics, and we have moved into physics that is specific to cardiac MR. So in this session, we will be concentrating more on one of the most important sequences that we often use in cardiac MR, and that is the phase contrast images. So the phase contrast images tell us a lot of data about the flow of the flow in the vessels, and also there are a lot of recent advances that are coming up in phase contrast like 4D flow. And so this is a very important session to understand what exactly is phase contrast and how we can utilize it in our day-to-day cardiac MR practice. And for this session, we have two of our stalwarts. For the session will be given by Dr. Rajesh Kannan sir. He needs no introduction. So he's a professor at Amrita Institute of Medical Sciences in Kochi, and he is also one of the founder members of IACI. I welcome Rajesh Kannan sir for this session. And we also have our dynamic and ever-present Dr. Sanjay Vishwamitra sir to moderate the session. So he is also with us. He will also give his inputs. And I hand over the session to Dr. Rajesh Kannan sir to take forward this.
Yeah, thank you, Dr. Pudiyavan. So without wasting time, I'll move to my lecture. Yes, hope it is visible. Okay, so what we are discussing in the last four sessions are the basics of the MRI physics, and today we are going to discuss about the one of the important sequence known as the phase contrast MRI. And today, to make it simple, I am not going to discuss about the too much of our physics, and mainly I am going to discuss the applied physics, what the every radiologist must know when they are using this pulse sequence, because physics of the core physics may be a little difficult to understand, but yeah, we should know some of the basic concepts of the phase contrast MRI physics. But much more important thing is how to apply and how to identify the artifacts and how to rectify them. So that's what I am going to discuss today. So you can expect the following things from my presentation. So it's going to be for about 45-50 minutes, and the first I am going to cover some of the basic concepts, the physics in behind the pulse sequence, and then I'll concentrate on the practical aspects like planning tips, the post-processing tips, and the common clinical applications, including the cardiovascular applications. Then we'll have a short break for a Q&A session. I request all the participants to send their queries in the chat box, so that all those queries can be discussed during the discussion time. And I'll complete my talk by discussing the artifacts and the remedies. So to make it very simple, what is phase contrast MRI technique used for cardiovascular imaging is it basically contains the flow information. So what we will be doing is simply we will be doing a cross-sectional imaging across a vessel, and that image will have a data of flow information, including the velocity of the spins inside the particular structure. So that using that data, by doing the post processing using the computer model, we will be finally getting the graph like this. So we can get the blood flow within the any particular vessel. Now we can identify the or calculate the positive flow, negative flow, and all. So this is the basic simple thing to describe it in a single slide. But going to the physics part of it, so as we all know and what we have discussed so far, the MRI basically we discussed about this longitudinal magnetization and the transverse magnetization and how the image is formed. And when you look at the conventional MR imaging, the signal intensity or the gray scale of the any pixel is mainly based on the signal strength of the mainly the transverse magnetization, which is going to represent as a different gray signals. Now whether it will appear brighter or darker is basically depends on the transverse magnetization and its the signal amplitude. Even though when we are after acquiring the data during the Fourier transformation, it's not only get the final signal of each pixel, the data also represent the exact phase and the frequency of the each spin in the different pixels. But generally we don't use that phase information. Even though the phase information is available, it doesn't have much clinical use, so that data will be discarded, and only the anatomical images are is produced at the end of the each pulse sequence. But if you look at it, this phase data is used in the different imaging modalities. One very well known pulse sequence is the so-called susceptibility weighted imaging. Most of the new generation susceptibility weighted images, we can actually extract the phase component of the image. We can get both the phase data and the magnitude data, and now we are using this data to differentiate calcium versus hemorrhage. Whereas when we are talking about the phase contrast flow study, it primarily it is the main MR technique which is used for flow analysis. So also known as the phase contrast cine MRI or the velocity encoded MRI sequences, and it is the main sequence which is used to assess the blood velocity and the blood flow. And what is the underlying principle? The basic principle of phase contrast flow study is the phase shift of the signal from a moving proton is directly proportional to its velocity. So basically, any moving protons going to produce a phase shift when we are applying a particular pulse sequence to produce that effect. And the phase shift which will be occurring here in the phase contrast MRI is similar to the Doppler. So we all know that the principle of a Doppler is basically the any moving flowing structure will produce a Doppler shift which will be can be visualized as a red or a blue color, as well as we can even quantify the velocity. So something similar will be happening in the phase contrast flow study also. So how exactly we are going to measure this the so called the phase shift, we will discuss it. So to get this phase contrast MR images, in addition to the routine RF pulses, we will be applying a one bipolar gradient. So we all know that the basic principle of a gradient is, so when we are changing the the gradient within the magnetic field, it basically either increases the local magnetic power or reduces the magnetic power in a smaller quantities. So what will happen is, so along the course of the gradient, the tissues will increase its phase. Okay, so it's basically will the precision frequency will keep increasing along the positive aspect. If you are producing or giving a negative gradient, then it will be on the opposite side. So when we are applying this gradient, bipolar gradient, first we will apply a positive gradient, then immediately followed by a the negative gradient, which will be at the exactly the same level of the positive gradient. So let us see what will happen when we are applying the positive gradient. So the tissues along the gradient, since they are experiencing different level of magnetization, as we move from the say left to right, the tissues on the left side will experience relatively lesser the magnetization as compared to the tissue at the on the right hand side. So what happens is, if the tissues are stationary, not moving, as we move from this end to this end, the phase will be keep increasing. So the tissues along along this direction will gain more phases, so they will have a different phases. But what will happen when you are applying the negative gradient of the same bipolar gradient? The tissue which is receiving maximum positive gradient now will face the maximum negative gradient. So what will happen is, it will start dephasing to its original position. So if you look at any of these stationary protons and any location, at the end of the bipolar gradient, there won't be any phase shift. The net phase will be 0. Suppose if you assume that some protons which has moved from one place to another place along the direction, like the spins within the blood vessel, or the protons within the vessel, what will happen is, at the start of the positive gradient, they will be receiving, say somewhere here at this point, they are receiving they are facing the gradient. So there will be some amount of phase shift. But when we are applying the negative gradient, since this protons which has moved from this place to the next place, it will face a different the gradient strength. So there will be a net shift in the phase of that proton. So that can be measured and can be used for a final image. So to sum up, what exactly we have done is, we are applying a bipolar gradient, both positive phase and the negative phase. And if you look at the different stationary tissues, as the gradient in the strength increases, they will be having a different phases when you are applying the positive gradient, and when you are applying the negative gradient, everything will come back to its normal. So there is no net phase shift. Whereas any moving protons along the direction, they will have a phase shift, and the important thing is how much the phase shift will depends on how far it has moved. So that means it will be directly proportional to its velocity. So in a nutshell, so what is the basic concept of this phase contrast MRI is, when we are applying the bipolar gradient, the normal stationary tissues won't have much flow signals, whereas those tissues, the blood vessels which are patent, will have a phase shift, and they will be shown as a bright or the dark signals, and this strength of the signal will be directly proportional to its velocity. So that is a very important concept, and this bipolar gradient, this is marked in the yellow color, will be applied after the 90-degree radio frequency pulse will be applied along the along with the slice selection gradient. Okay, and the rest of the sequences will be remaining same. So the only additional thing will be applying a bipolar gradient, and not because normally also when we are using these 90-degree pulses and 180-degree pulses, there will be some amount of background phase shift can be there in the stationary tissue also. So what we have to do is we have to do a two sequences, one without the bipolar gradient and one with the bipolar gradient, and when we subtract this we will get the final phase contrast image. So that is the basic principle of the phase contrast flow study. So when you are acquiring the image like this, we will get the final phase contrast image will be like this, and here basically the flowing structures like vessels like an iota or IVC, they will either appear bright or dark depending on the flow direction, and the stationary tissues will appear relatively gray, and the signal intensity of this brightness or the darkness will be directly proportional to its velocity. So that is the important concept you have to understand. And here the one more thing you have to also know is this the flow is also depends on the velocity encoding which we have to set beforehand, so that any velocity which is occurring outside the set velocity may not be represented correctly in this part. So coming to the some of the practical points when you are doing the phase contrast MRI, one important thing we have to know is whether we have to do in a free breathing or with the breath hold. So there are advantages and disadvantages. When you are using a breath hold sequence, it is much faster. Usually will take about 10 to 15 seconds. So in order to use this as a breath hold sequence, we will make it little faster. Whereas in a free breathing sequence where we have to take a multiple averages over multiple heartbeats, so say in the range of 30 to 60 seconds we can use. So the main in most of the clinical applications we can do with the breath hold sequences, whereas the some of the physiology will be altered in a complex congenital heart disease, especially post Fontan situation. What happens is in a Fontan after a Fontan surgery, the most of the blood flow is mainly based on the respiratory variation. So if the patient is, when you are doing a breath hold, whether during inspiration or expiration, the physiology is completely altered, then it won't represent the correct the blood flow. So when you are doing a complex congenital heart disease, it's always recommended to do with the free breathing. Whereas for a conventional MR imaging, just if you want to confirm the blood flow in the ascending aorta or in the pulmonary artery, in that cases the breath hold sequences are more than sufficient. And the second thing is when we are doing the PC flow, we can either look at the in-plane flow or the through-plane flow. For most of the clinical applications, for quantification, we have to do the through-plane sequence, whereas just for visualization, we can use the in-plane PC. And when we are doing a through-plane, we have to make sure that we have to plan perpendicular to the long axis of the vessel, and we have to use the correct Wenck, otherwise it will produce aliasing, and also we have to use the correct temporal resolution by adjusting the views per segment and the number of phases. Also you have to use a good spatial resolution in order to minimize the any overlap artifacts. So this is the difference between an in-plane flow versus a through-plane flow. If you want to do any quantification, if you want to calculate what is the forward flow, what is the reverse flow, then you have to use only the through-plane. Just if you want to know the flow direction, or if you want to look at the highest velocity, so that you can plan further through-plane at that level, then you can use the in-plane images like this. Then coming to the another important thing in the planning is the how will you exactly do the planning. So ideally we have to plan from two orthogonal plane, and whenever possible, if you have an MR angiogram data, it will be well and good. Otherwise, you can use the cine sequences. For example, if you use two different LVOT views, then you can take the aorta generally at the sinotubular junction, and the MPA we can take between the pulmonary valve and the pulmonary bifurcation. And for SVC, it's recommended to take above the esophagus vein. For the IVC, you have to take it above the level of the hepatic vein insertion. But the important thing is you have to avoid any dilated segment which is having a swirling flow. If you do a PC at that level, you are going to get a erroneous results. So this is the importance of taking a two long axis view, and you have to make sure that you are cutting exactly perpendicular to the long axis of the vessel. So use two long axis plane, for example in an aorta like this, and an MPA we can take the the RV outflow tract view, or the axial view of the at the level of the MPA bifurcation, and basically you will be taking the MPA flow between the level of the pulmonary valve and the MPA bifurcation. Whereas when you, these type of the things can be even using the localizer, you may able to get a reasonable good angulations. Whereas if you want to do smaller structures like a pulmonary vein, like in this case the superior pulmonary vein, if you want to take a blood flow across the superior pulmonary vein, it's always better to do an MR angio first, or some type of a 3D imaging including the 3D SSFE sequence, and then you get a true long axis of the vein first, then you take a true cross section. This is very very important. Now we will discuss what will happen if you don't take a true cross section in the artifact section. Also we should use a correct Wenck, that is the depending on the velocity, the expected velocity in that particular vessel. For most of the venous structures like SVC or IVC, we can use the Wenck somewhere in the range of 50 to 90. Now less than 100 centimeter per second may be sufficient. Whereas when we are doing the ascending aorta, we can go up to 150 to 200 centimeter. For the pulmonary arteries under the branch pulmonary arteries, we can use 80 to 150, and for pulmonary veins around 50 to 90 centimeter is enough. But if you know that there is a expected stenosis, and if you have an echo velocity already, if you know that a particular vessel showing a velocity of say 300 or 400 centimeter, we have to use that Wenck for a phase contrast MR imaging, so that we can reduce the aliasing artifact. So we will discuss why we cannot use the highest Wenck, because I told when you are using a lower Wenck, we will get an aliasing artifact. But can we use the the highest Wenck possible, like 500 centimeter per second for all the vessels? So that we will discuss in the later part of my talk. And the another important component when we are doing the planning is the number of views per segment. So depending on the heart rate, if the heart rate is less than 50, we can go up to 4 segments views per segment. Whereas if the heart rate is generally will be in the range of 75 to 100, so ideally we have to use the segments of 2. This is mainly applicable when you are doing a free breathing sequence, but if you want to do a breath hold sequence, then sometimes you may have to go with the higher views per segment. And when the heart rate is more than 100, when the RR interval will be less than 600 milliseconds, so you can use only 1 views per segment. So only when you use these the views per segment correctly, you will get a much better temporal resolution. And another important thing is the number of phases, how many phases you are going to take per RR interval. Also, very important. Ideally, you can take 20 to 30 frames per RR interval. We usually take 24 frames for all cases, which will be a better balance between the good temporal resolution, as well as even you can take 40 or 50 frames per second. But the problem is all the images you have to do the contouring. So the post processing will be very time consuming. So the best will be somewhere between 20 to 24 is more than sufficient. You'll get a good temporal resolution. At the same time, the post processing also will be more easier. So what will happen if you are using a lower frames per second? So even though it may have the same type of a graph, but the problem is it may miss the mainly the peak velocity. So it may correctly identify the total forward flow and the reverse flow ratios and all, but and even the curve, the shape of the curve and all can be normal. But the important problem is if you are having a lesser sampling, the chance of missing the peak velocity is very high. So try to keep at least the recommendation is minimum will be 15 frames per a total of at least 15 frames should be there per RR interval. So to sum up, when you are doing the planning, so now you have to do the we can do either a free breathing sequence or a breath hold sequence. I told breath hold sequence is most of the time is sufficient, but if you are doing a complex congenital heart disease, it's always better to do with the free breathing. And in order to get a true perpendicular plane, you try to use a MR angiography or a 3D SSFE sequence, and the slice thickness also is ideally has to be 7 millimeter for the large vessels like an aorta, and use the thinner sections like a 4 mm or 5 mm for a coronary artery or for a pediatric age group, and try to use the smallest FOV with reasonably good signal to noise ratio. For peak velocity measurements, you have to plan both parallel as well as perpendicular to the jet, so that you know where exactly the maximum velocity you are going to get, and try to use at least 20 phases for better temporal resolution, and we have to also use the correct Wenck and the views per segment. It's also important to know how to do the post processing. So first of all, now we have to check all the slices in both the magnitude image and the phase image or the velocity image. In the magnitude image, you have to look for any phase rough artifact, which sometimes can be difficult to appreciate on this one on the velocity image. So you look at the phase in the correct anatomical magnitude image also for any other artifacts. Then you try to contour it exactly on the wall of the vessel without any overlap with any adjacent structure. And if you look at the during the systolic phase, the structure will appear either bright or darker, which will be easier to contour, whereas during diastole it will be relatively grey. So in that case you can use the magnitude image. So it's very, very important to always cross check whether what you are contouring is correctly matching in the magnitude image also. So what are the things how will you interpret these images? So there are lot of information is available in the final images. So as well as in when you are doing the post processing, it's not only the looking at the final values. Now if you look at the images itself, now it will give you important information like whether a particular vessel is patent or not, whether like if you are looking at the any say graft or anything, we can say whether it is patent or it is thrombosed. So we can look at the flow inside any structure, as well as we can use this phase contrast imaging even to identify the septal defects like an atrial septal defect or a ventricular septal defect and its location. All those things can be identified. We can also look at the flow direction. Here mainly by comparing the known flow, we know that the ascending aorta will flow from inferior to superior direction, whereas descending aorta and the SVC will flow from superior to inferior direction. So if you are having some structure like on the say some vessel lateral to the arch of aorta, And if you want to differentiate whether that is a double SVC versus a vertical vein of the anomalous pulmonary vein, you know that if it is an SVC, it will flow from superior to inferior direction, whereas the vertical vein of the TA PVC will flow from inferior to superior direction. So you can look at the flow direction. We can also, important thing is look at the pattern of the graph. Now will be very useful, especially when you are doing the AV valve PC to identify the diastolic dysfunction. We can look at the E wave and the A wave, as well as in the case of pulmonary regurgitation, like in this case we can see that there is a forward flow and the reverse flow. By looking at that graph itself, we can say that there is a valve regurgitation. Then when you are looking at this summary of the result, we can look at the peak positive velocity, how much is the maximum velocity, and if you want to calculate the gradient across the stenosis, we will be using this maximum peak velocity. And we can also look at the what is the average flow, or otherwise known as the stroke volume. So this is the case of the flow, otherwise known as the stroke volume is 3.7 liter. And we have to look at the what is the positive flow and the negative flow. So the negative flow will be indicative of a regurgitant flow. For example, if you want to calculate the regurgitant fraction of a regurgitant volume and regurgitant fraction of the pulmonary regurgitation, the negative flow will indicate the regurgitant volume, and the regurgitant fraction can be calculated by regurgitant volume divided by forward flow multiplied by 100. So we get lot of information using this phase contrast flow studies. And another important thing is we have to always internally check what you are getting the numbers are matching with each other. So in general, the main pulmonary artery flow should match the RPA plus LPA flow, which should be equal to the all four pulmonary venous flow, which should be equal to the RV stroke volume. So similar thing will be applicable on the left side. So you need not do all the flows for each and every case, but whenever you are doing, you have to check that, make sure that they are all internally matching. So if there is any mismatch when you are getting when you are doing the PC, whenever you see any mismatch, then you have to suspect either a atrioventricular valve, I mean the valve regurgitation, or a shunt lesions like a septal defects or a PDA or any collaterals. So coming to the different clinical applications, so one of the application of a phase contrast flow study is in a CSF flow study. You all may be doing it in order to assess either the third ventriculostomy site, or you may be doing it at the level of the aqueduct of Sylvius for a normal pressure hydrocephalus. So the same principle is applied here, and we are using this PC study for getting the angiographic images also. So most of the 2D localizer images which we are planning for a dynamic post contrast study is a phase contrast 2D MR angiography sequence. So even 3D MR angio also possible using this phase data, but 3D phase contrast MR angio is time consuming. So that's why 2D phase contrast MR angio is used. Coming to the important cardiac applications, as we discussed earlier, it is very useful to identify the presence of flow, like to say whether a particular shunt is patent or thrombose, to know the direction of the blood flow, whether it is showing a forward flow or reverse flow. It can use the PC data to identify the gradient across the stenosis by looking at the peak velocity. We can calculate the valve regurgitation. The leaking valves, we can calculate regurgitant volume and regurgitant fraction. We can also calculate the shunt by looking at the QP and the QS. We can also use the PC flow to assess the collateral flow circulation. For example, in the case of the coarctation of aorta, if you look just by looking at the collateral flow, we can quantify the severity of the coarctation. Also, we have to look at the waveform. For example, in the case of pulmonary hypertension, and if you do a PC across the pulmonary artery, it will show multiple peaks during the systole. So that is one of the characteristic feature of pulmonary hypertension. So we can look at so many aspects when you are doing a phase contrast flow study. So I'll break for a short thing. So Dr. Sanjay, is there any queries? Anything you want to add?
So Rajesh, that was a very good presentation of the basics, and there are a few questions that are being asked. So one of the question is about the velocity encoding gradient, and you gave different velocities for different structures on a slide. Very nicely you gave that. So the question is, on what basis do you actually fix that Wenck, say for the aorta, if you're measuring the ascending aorta? On how do you know it's 150 to 200 centimeters per second, and how do you alter it if required?
Yeah, this is very important question. So whenever you are starting the PC flow studies, this one information is very important, and you should know how to identify the correct Wenck. So some vendors gives the so-called Wenck scout, similar to the frequency scout and the TI scout. There is if you have the Wenck scout, you can use that. That will give you the images with the different Wencks, so that we can correctly identify the right Wenck to use it. But the only thing is, for each and every structure we have to use that Wenck. If you are using say true cross section, then that is okay, whereas for the unknown structure, of course you have to use one additional sequence. The second option is, we can use a fixed numbers like what I showed, like 150 or 200, and we have to look at that image, and on the image if it shows the any aliasing, then you have to increase the Wenck. I'll anyway come to that slide. So depending on the size of the aliasing, we can now go to either say 50 to 60% higher to say only less than 10 to 20% higher. So the important thing is, in general, now we can use somewhere around 150 to 200 for an aorta. Whereas for the venous structure, generally we will start with the less than 100, so 70 to 80 is more than sufficient. And the other thing is, whenever you are looking at the stenotic vessel, if most of the cases usually echo will be done, so the MRI will be done after the echo. You go back to the echo report and see, they usually will, for example, in the case of hypertrophic obstructive cardiomyopathy, they will mention that the gradient across the LVOT is the peak velocity of say 300 or 400. So once we know that velocity, we can use that same velocity as a Wenck.
So the second question on the same lines is, what about when you have these complex procedures, for example, post-operative Fontan or Glenn or any of these other complex procedures? In that case, how do you start off with the Wenck assignment, and where do you actually measure it?
Yeah, see, this is again very important. So when you are looking at the PC's flow study, now as we know that there are so many vessels are there, and we can take from any vessel, but in a case like say a simple ASD or a VSD or a PDA, where if you want to just calculate QP and QS, only two level generally can be sufficient. You can take only at the MPA level and one at the ascending aorta usually will be sufficient. Whereas in a complex heart disease like a post-Fontan, where you can have an abnormality at many level, so in those cases usually we do one at the ascending aorta level and the descending aorta level and the SVC level. See, one thing is, if you do the true axial section at the level of the right pulmonary artery, we get all three vessels at the same plane, like SVC, ascending aorta and descending aorta. All three can be calculated using the single level. Whereas for the branch pulmonary artery, right and left branch pulmonary artery, we have to take separately. Similarly, for pulmonary veins, all four pulmonary veins you have to take separately. Sometimes there may be accessory vein, so you have to take that also separately. And similarly, the Fontan flow also we have to take at the multiple level, especially if it is as a fenestration, then you have to take one below the level of fenestration, one above the level of the fenestration, so that we can calculate what is the flow happening across the fenestration. And the other important thing is, I told like an RPA or branch pulmonary arteries, you will be taking say some around 150 centimeter per second. Whereas in a post Fontan, the blood flow is the pulmonary artery is not getting its blood from the right ventricle. Instead, it is directly connected from the vena cava. The SVC and the IVC are directly connected to the pulmonary artery. So the velocity won't be very high. So you can start off with only 100 or 120, then only if it shows any aliasing, then you can go for a higher venk. So in those cases, it's better to always start with the lower venk, because the important thing is, if you first start with the very high venk, then we won't know that whether we are using the correct venk. So the best will be start with the lower venk, because we know that if it is very low for that vessel, then you will get an aliasing artifact. So either you can use the venk scout, or you start with the low venk like 50 to 100 centimeter. Then once it shows aliasing, then you can keep increasing.
The last question before you get back to your topic, Rajesh, is that there are a couple of different options of getting phase contrast. One is a single breath hold image, and the other is the three sets of images where the patient is free breathing and you do an average of to get phase contrast as well. Do you have a preference for one or the other? Do you find one works better than the other?
Yeah, so we usually use for most of the cases, the breath hold sequence, where you cannot use all three the values, which will take a lot of time. For things like just if you want to calculate the aortic regurgitation or say AV valve regurgitation, where you need just one flow at the level of the say LVOT or at the ascending aorta, breath hold sequence of 15 seconds through the single through plane PC is more than sufficient. Whereas only when you are doing complex flows like post Fontan studies, then we usually do a free breathing sequence, and each level this free breathing sequence usually will be each level will take about 40 to 60 seconds, and where we may have to do more than 12 or 15 vessels. So that itself usually will take about 15 to 20 minutes. So that will be very time consuming. That is needed only in the case of very complex diseases, where you have to take multiple levels. Otherwise, for a single levels or one or two levels, it's better to go easily you can get away with the breath hold sequence itself by taking a true single plane through plane PC.
Thank you, Rajesh. Shall we continue with the rest of the talk?
Yes, yeah. So of course, we have the recent, newer techniques like a 4D flow and all, where we can take, once we acquire the 4D, the data of the entire chest, then we can do a reconstruction later. So I will come to that point. Okay, so we'll move on to the, we'll continue to my talk. So the last part of my talk is on the pitfalls and its remedies. So whenever we are doing any imaging, it's very important to know what are all the different types of artifacts which we can get, and how to overcome those artifacts. One of the most important and the simplest artifact is the so-called aliasing artifact, and the remedy is very simple, and identification also is very simple. Just you have to increase the venk. Second is the signal loss due to the flow turbulence under the jet we can happen. So its best way is to avoid the taking from that turbulent jet, and if you are doing it, try to use the TA as low as possible. But one of the major thing, or one of the difficult thing to understand as well as the difficult thing to correct is the so-called the phase offset errors. These are all due to the magnetic field inhomogeneities happening within our area of interest. This is cannot be completely avoided, but the one way which we can reduce it by keeping the region of interest close to the isocenter as possible. See, if the baby is very small, now what you can do is, instead of keeping over the table, just keep some sort of a pillow or something, so that you can raise it to the isocenter level. Now also you can use phantom correction, even though it is very time consuming, but it may be useful in few cases. And also we cannot do this PC flow studies very close to the metals, because it will produce a lot of phase offset errors. And wherever there is a pulsation artifact, you can change the phase encoding direction. You can just switch the phase and the frequency direction to get away with the pulsation artifacts. So this is the aliasing artifact, which is one of the most common artifact, and this is due to the use of a very low Wenck, and if the velocity of the vessel is higher than the Wenck what we have selected, the higher velocity spins will be appearing as the flow opposite to that of a normal flow. For example, in this case it is appearing bright in a normal flow of dark background. So once you use increase the velocity, then the vessel is appearing homogeneously dark. So why we are getting this the aliasing artifact? So the important concept to understand is, so this when we are setting the Wenck say as 100 centimeter per second, what happens is the system will calculate the minus 180 to plus 180 degree phase shift within that 100 centimeter per second. So suppose if any spins having a say 405 degree phase shift, it will be similar to the phase shift of a proton which is having only 45 degree. So that's going to overlap with each other. Similarly, if any protons having a phase shift of 90 degree and the minus 270 degree going to overlap with each other. So in other words, in a simple terms, so whenever we use very low Wenck and the velocity of the vessel is too high for that Wenck, it will produce aliasing. So how will you correct this aliasing, and how much Wenck you will be able to increase? So as a rough rule of thumb, what you can do is, we can look at the total surface area of the total area of the aliasing as compared to the structure. Suppose if it is we are seeing the aliasing say somewhere around 20% of the area, then you can increase the Wenck by around 30 to 40%. That may be sufficient. Whereas if the getting aliasing very small, only a small dot, then even increasing by 10 to 20% may be roughly sufficient. Whereas if we are seeing an entire vessel is showing an aliasing, then you can nearly double the Wenck. So by using the trial and error method, once we know once we do few cases, then easily these things can be identified. And whenever you have a Wenck scout, which some of the vendors are providing, you can use that also. So now when we are talking about the Wenck, since lower Wenck produce the aliasing, so why can't we use the highest Wenck like a 500 centimeter per second for all cases? So if you look at this experiment which was done using a phantom and using a tube of a fixed velocity, and when the PCs were done with the different Wencks starting from say 74 to 550 centimeter per second, and this is the original the yellow line indicate the actual velocity of the particular structure, and as we keep increasing the velocity, the Wenck, what happens is the chance of error is very high. So as we if the Wenck used is more than say twice or 3 times that of the actual vessel velocity, the chance of error is very high. Why? Because you get a lot more noise, and the identifying the peak velocity will be really difficult. Whereas if you look at the total blood flow within the vessel, now even if you increase the Wenck to significantly 3-4 times, generally the total flow, forward flow or reverse flow, that won't get affected. But if you are looking mainly for the peak velocity, definitely it will be you will get a erroneous report. So basically it indicate that very low velocity structures cannot be identified and it cannot be differentiated from the background noise. So that's why now we have to always use the correct Wenck, so that we will get a very smooth picture with a good suppression of the background especially when you are, our main concern is the peak velocity. Suppose if you are not worried about the peak velocity, just if you want to know the blood flow, you can be use slightly higher wing, and still you can get a the much better data without relatively minimal error. So, when you are looking at the only the blood flow. And the second important thing we discussed about the temporal resolution. So why do we need to do at least 20 frames per second? So even though we can get the similar curves using the say 5 to 10 frames per second, and if you calculate the say even regurgitant fraction and all can be nearly equal, but if you want to again calculate the peak velocity, definitely you have to use a more phases per cycle. And another important thing which we have discussed is regarding the imaging plane, and how why we have to take perpendicular to the vessel. So what will happen, suppose if you ideally you have to take almost a true cross section of the image. Suppose if you take oblique to the vessel, what will happen is, as long as the error is as long as the angle of the difference is say less than 10 degree, the chance of error is only about 2%. As the angle increases to 30 to 40 degree, then you have an error of nearly 30%, which is not acceptable. So that's why we have to always take a true cross section. This will affect both the velocity as well as the total blood flow will be calculated erroneously. So always you take a true perpendicular to the vessel of interest. And other thing is the phase offset error, which are difficult to correct, and different systems gives you different methods of correction. So this is one option where we can use the background correction. And again, when you are using the background, you have to make sure that it's not overlapping with any of the vessels. You have to use the structure close to the vessel of interest, and here we can actually manually we can decide whether you want to take a larger background or a relatively smaller background. So, but some of the problem is when if there are any metallic artifacts or anything, and if there is any phase shift artifacts, then these background corrections sometimes may not work correctly. We can also use phantom correction. So after doing the human study, we can keep a phantom like this, and we have to repeat the same pulse sequence with the same parameters. And one of the drawback of that is the phantom has to be exactly at the same location. So for example, in this case the phantom was slightly away from the region of interest. So look at the curve was completely erroneous. So then we have to reposition the phantom to get the correct flow like this. So using the phantom sometimes can give an additional errors. So and it's involves lot more time. So many centers don't use this phantom correction routinely. So the best practice will be no need to use this phantom correction. Now if you can use a good shimming, and there are not much metallic artifacts, the conventional PC imaging is more than sufficient, and it's very difficult to correct these phase offset errors. Also, we try to avoid the areas where there is too much of flow turbulence, and where there is a grossly dilated vessel. So in that case, what you can do is you try to use the other structures. For example, if the MPA is grossly dilated, then you can use a RPA and the LPA flow separately. So take separately RPA and one flow at the LPA, then you can add together, then you can get a total pulmonary blood flow. Also, now you can you have to look at for the pulsation artifact. For example, in this case the phase encoding direction was right to left, and if your area of interest is on the SVC, in this case there is a lot of pulsation artifact from the ascending aorta which is overlapping with the SVC. So in that case, what you can do is you change the direction instead of right to left to anteroposterior. So you can see that there is no artifact occurring at the level of the SVC, so that the value of the SVC flow will be more accurate. So whenever is needed and your area of interest is of the particular vessel where you get the pulsation artifact, there just by changing the phase and the frequency direction will be helpful. So to summarize the different pitfalls and its remedies, the first and foremost is the aliasing artifact, which can be easily corrected by just by increasing the Wenck. But as I told, so we should not use the highest Wenck. Try to use the Wenck roughly 20 to 30% higher than the actual velocity, which will give you the most accurate the flow information. For better temporal resolution, use at least 20 phases. We use 24 phases consistently, and try to avoid any major angulation. So that's why you take a MR angiography or a 3D sequence, and you plan from that, so that you will get a true cross section of the vessel. To reduce the phase offset error, keep the your region of interest to the isocenter of the magnet, and if needed, especially for some of the complex flows, you can use the phantom correction. And you don't do very close to the metal, it will produce lot of artifacts. So whenever there is a pulsation artifact, try to change the direction of the phase. If it is the right to left, you can change it to antero-posterior, so that the pulsation artifact won't overlap with our region of interest. And there are newer pulse sequences, lot of advancements happening. One thing is the so-called 4D flow, where in a standard 2D flow usually will do only the 2 scans in the single direction, whereas in the 3D PCs we can take multiple directions in XYZ, whereas in a 4D flow what happens is it is a respiratory gated free breathing sequence, where multiple slices covering the entire chest is possible. Only thing is it is time consuming. It will take about 10 to 15 minutes even with the newer type of sequences. Now there are lot more advances happening where the time is significantly reduced, but major advantage of this the 4D flow is we can simultaneously acquire all the vessels. We can say acquire both the pulmonary artery and the aorta. We can look at both the ascending aorta, arch and the descending aorta, and even smaller vessels can be identified. So just by looking at these vessels, another advantage is, even if you don't, even if you have forgotten to take a PC at any particular vessel, say for example, suddenly if you want to look at the right and left brachiocephalic veins for some reason, even those things are possible. So, and we can also look at the flow direction. It gives a lot of information, especially in a post-Fontaine procedure. If you want to look at the different flow dynamics, how exactly the blood flow is happening from say IVC and the SVC into the pulmonary artery, whether blood from the IVC is going into the both the branches. If you want to identify that, if you do any contrast angiogram, CT angio or MR angio, nothing will be helpful, whereas the 4D flow will be very helpful to show that which direction the blood flow is happening. We also have the other recent advances like a 5D flow, which is self-gated free breathing sequences are coming up. So these are all currently not available in a commercial purpose. It's only in the research purpose, and a lot of research is going on, and where the understanding the physics may be a little complex. As long as if we know that how a 2D PC works, then it will be easier to understand the other newer applications. So to conclude, the phase contrast flow study, it contains information regarding the physiology, the blood flow, and the velocity of the velocity information within the vessel, and you have to always cross check the the PC numbers, whatever numbers you are getting, you don't use that data. You always compare it with the data which you are getting from the volumetry, because anyway we are doing the Sataxis Cine and we will get the end diastolic volume, end systolic volume and the stroke volume. You compare the say LV stroke volume with the PC flow at the aorta. So for normal cases without any regurgitation or shunt lesions, if you keep doing the cross checking with the volumetry and the flow data, then for the pathological conditions will be very helpful, so that you can consistently get the flow data very accurately. So for further information, you can read this the chapter on the textbook of CT and MRI in congenital heart disease. We have an exclusive chapter on the phase contrast flow studies, where the most of the topics covered today are there with the good illustrations, starting with the basic concepts and its common clinical applications, the different artifacts and the different methods to correct the artifacts, as well as the other methods of using this phase contrast flow study. Everything has been nicely discussed in this chapter. So I recommend everyone to go through this chapter in this textbook of CT and MRI in congenital heart disease. Thank you very much.
Rajesh, thank you again. That was an excellent talk. So we just have a couple of more minutes. So let's end up with a couple of practical points, just to reinforce some of your practical points. So the first one that I want to ask you is, in a routine adult CMR, not a congenital patient, in a routine adult CMR, what are the routine phase contrast sequences that you recommend?
See, things like a viability scan, generally we don't do any PCs, it's not required. Only thing is, initial period what we did is we take the one at the aorta and one at the MPA, just to confirm that what we are doing the quantification of the by volumetry is accurate or correct. Otherwise, when you are suspecting a valve regurgitation, suppose if you are suspecting an aortic valve regurgitation and the mitral valve regurgitation, just you have to do only at the aorta. Either you can take it at the ascending aorta like sinotubular junction, or you can take it at the level of the LV outflow tract. For both the aortic regurgitation, you can directly calculate using the aortic PC. The regurgitant volume of the aortic PC will be equal to the aortic regurgitation. Whereas for mitral regurgitation, we can use the forward flow of the aorta, which needs to be subtracted from the LV stroke volume. So the LV stroke volume minus the aortic forward flow will be equal to the mitral regurgitation. Similarly, if you want to do it on the right sided valve, then we can take one PC at the level of the MPA, so that we can calculate both the pulmonary regurgitation as well as we can calculate for the tricuspid regurgitation. Otherwise, next is when you are for planning a shunt lesions like a left to right shunt, generally we will take at least one at the ascending aorta. When we are doing ascending aorta at the level of the right pulmonary artery, we will get all three vessels like a SVC, ascending aorta and the descending aorta. So one way of internal checking is, normally the ascending aortic flow should be equal to the SVC plus the descending aortic flow, because the SVC flow returns the aortic arch branches. The remaining flow is going to come to the descending aorta. So the ascending aortic flow should be equal to the SVC plus descending aorta. So that one level of the ascending aorta at the level of the right pulmonary artery will be good enough to calculate the total systemic flow. Then we can take one at the main pulmonary artery, and if the main pulmonary artery is dilated, we can take it at the right and the left pulmonary artery, and which can add together. Whereas in a complex diseases, we have to take both at the ascending aorta, descending aorta, SVC, IVC, MPA, branch pulmonary arteries and the pulmonary veins. These are the minimum things, and depending on the different shunts, we can take it from that level. And if you are seeing a, say, a large MAPCA, and if you want to quantify, or if you are looking at the PDA, if it is seen directly, and if you want to quantify the PDA, you can take directly from that.
Right. Thanks, Rajesh. Now, just for somebody who's beginning and trying to understand phase contrast, understand the graphs, and understand the quantification, you mentioned that you can use that to corroborate your stroke volume to see whether your stroke volume measurements are as accurate as that. Are you allowed? Do they need to be within a certain percentage or a percentage difference with each other, or do they need to be exact? How does it typically work?
Yeah, so that again a very important thing to understand. Suppose when you are doing a volumetry and the calculating LV stroke volume is coming as say 5 liter, and if you are looking at the ascending aortic flow, it never exactly will be 5000 ml. So up to the range of 5% above or below the value is very well acceptable. So you should not get a more than 10% difference. So within a 5% is reasonable. Always you will get a minimum 5% the differences. That is both intrinsic, because we are now looking at the completely a different pattern, and we are comparing a different methods, like in a volumetry where now we are calculating the contouring the end diastolic and systolic volume, and the contouring, there can be a lot of manual variations can happen. And when you are looking at the LV stroke volume under the ascending aortic flow, when you are looking at the sinotubular junction, and naturally we are not calculating the flow which is going into the coronary arteries, because that small amount will be going into the coronary arteries. So the difference will be there, always the small amount of difference going to be there, and which never ever will be exactly same. So anything 5 to some people recommend up to 7% is within the acceptable range. It should not be say 20% or 30% difference is means then there is some error. Then if you keep doing contouring correctly, and if you can avoid all these artifacts, then will be much more accurate.
Similarly, Rajesh, if you're comparing just the main pulmonary artery flow on the right side compared to the aorta on the left side, are you allowed a certain amount of difference, or should they be close together? Because again, QPQS becomes a big question. When is it abnormal? When is it real? And so on.
Yes, yeah. So again, anything about 5% difference, you won't call it as left to right send. So say suppose if the pulmonary artery are getting say 5.3 liter and the aorta are getting only 5 liters, then that doesn't mean there is a shunt lesion. So again, that is within an acceptable range. So so only if it is say more than 10% difference, then definitely you have to suspect that there can be an abnormality.
Fantastic. Thank you again, Rajesh. That was a very nice, concise, but good talk where you even went over the pitfalls and how to correct for the pitfalls. I think that really helps all of us, including people like me who do routinely as well. I always enjoy learning from you. Back to Pudhiyavan to sum up the conference, sum up today's lecture.
Thank you very much, sir. So that was a wonderful session. Thank you, Rajesh Kannan sir, and thank you, Sanjay sir, for all your inputs on this session. So before we conclude this session, I'll just like to bring to the notice of all our participants that our 12th annual IACA conference this year will be a hybrid meet. So we will be meeting in person also. It will be happening from 14th to 16th October in 2022, and the location of the conference is also special this year because we are meeting after a hiatus of 2 years. So it will be in Bagmala Beach Resort in Goa. So we can all have much fun along with the academic experience. So the registrations are open. Don't forget to register for the conference. And as far as the physics webinar series is considered, so we will be meeting with the next session. The next session will be on June 10th. So we will be continuing on the CMR physics theme of these sessions. So the next session will be mostly concentrating on all these sequences, all the post-contrast sequences in cardiac MR, the dynamic perfusion images, the all-important delayed enhancement images, So we will be seeing the physics behind them and their the applied physics and the clinical applications and how to go about these sequences when you are actually doing the scans. So that will be the next session, and I once again thank Rajesh Kanan sir and Sanjay sir for this wonderful session. Thank you very much, sir.
Thank you all.
So all the previous sessions, recorded sessions also will be available in our website. So those who have missed the earlier webinars can watch the video at our website. Please visit the website iacain.org. Thank you.
Thank you, sir.
Good night. Yeah.
Good night, sir.